Well, hi there. I just wanted to go over some of the highlights of chapters 1 through 5. Hopefully, you've read the book or you're going to read chapters 1 through 5. And there's a lot of good information. What I like about this book is that it has a lot of analogies. And so that can be kind of helpful when you're reading this kind of thing. So I'm not going to go over everything that's in the book. I just kind of want to go over some of the high points. And one of the things that the book talks about are two terms, pharmacokinetics and pharmacodynamics. And you can see on page 4 of your book how they define those. But the way I always thought about it is pharmacokinetics is what the body does to the drug. So how it absorbs it, how it moves it around to the target tissues, and how it metabolizes it, biotransforms it, and then how it eliminates it. Pharmacodynamics is what the drug actually does to the body. What's the mechanism of action, and what does this drug do to the body? One thing I want you to realize is that when we talk about medications, they don't make the body do something that it can't already do. So, if you give someone a medication, it's not going to make them invisible. Our bodies can't become invisible. But what it can do is either augment what the body already does or block something that the body does or inhibit. So when we talk about how a drug gets into the body, there's two different classes of ways that a drug gets into the body. The first is enteral, and that's any kind of route that goes through the gastrointestinal tract. And then the second way is parenteral, which is a route that's outside of the gastrointestinal tract. When we look at the enteral method, these are drugs that maybe we take orally or sublingually and we dissolve under the tongue, or that are given rectally. It would also be medications that you might crush up and give through an NG or OG tube, or maybe if the patient has a G tube already inserted into them, or a J tube, some kind of PEG. Parenteral medications, again, are given outside the GI tract, and so those include, of course, IV, IM, subcutaneous, through inhalation, topically. Those would all be routes for parenteral medications. The only route that's pretty accurate and consistent is the IV route. All the other routes kind of depend on your patient and what condition your patient is in. When you look at the enteral routes, you have what's called the first pass effect, and basically what that means is the medications, when they're absorbed from the gut, the first place they go is into the portal vein, which goes into the liver, and so the liver has its first attempt at it before it gets distributed to the body, and sometimes the liver takes a lot of that medication and inactivates it just through metabolism in the liver. So generally, most enteral medications are given at a higher dose than a parenteral medication, just because of that first pass effect. I thought on page 6 of your book there was a really good analogy about the bioavailability of enteral medications, and it's called the gross pay analogy. So read that over, because I thought that was a really good analogy. The next term that we want to talk about is the half-life of a medication, and that's how long it takes for half of the medication, or half of the concentration of the medication, to decrease from its original level. So, like, for instance, if you give 6 milligrams of adenosine, the half-life of adenosine, 6 milligrams, is 6 seconds, and so after 6 seconds, there's really only 3 milligrams left. So 50% of it disappears in whatever the time the half-life is. So think about the 6 milligrams of adenosine. In 6 seconds, 50% of it's gone, so there's only 3 milligrams left. While in another 6 seconds, it disappears 50%. So after 12 seconds, there's only 1.5 milligrams left. After another 6 seconds, or 18 seconds in total, there's only 0.75 left, and it goes on like that. So different medications have different half-lives. What the literature basically says is that after 5 half-lives of the medication, then it's pretty much the effect on the body is gone. And so you can look at medications like we said, adenosine with a really short half-life, even a epinephrine, we give it every 3 to 5 minutes, so it has a really short half-life. And then you have drugs like amiodarone where their half-life is about 40 days. And so you can see amiodarone, it's going to take a long time to get out of somebody's system. Two terms that your book uses is biotransformation and metabolism. And it kind of makes you think that they're maybe different terms, but they actually kind of mean the same thing. And there's one of 4 ways that a drug can undergo biotransformation. Either you can have an active drug and it's turned into an inactive metabolite, or an active drug can be turned into another active metabolite, or an inactive drug can be turned to an active metabolite. Plavix is kind of one of those examples. Or you can have an active drug that turns to a toxic metabolite. Tylenol or acetaminophen is one of those examples. There's a couple of things that can affect the metabolism of a drug, and those are listed on page 9. But basically the age of the patient. Of course, as we get older, our liver doesn't work as well, and so drugs might stick around longer. The route of drug administration, the dosage, how much of the medication we give. There's some genetic predispositions that the patient might have. So in some patients, Plavix just doesn't work because of their genetic makeup. Diet or starvation and any kind of pre-existing disease, these can all affect how the body metabolizes medications. When we discuss the distribution of a drug, obviously drugs are distributed faster if they're given IV over any other route. Where they're distributed in the body is usually where the blood flows the best. And so those areas are the brain, heart, kidney, and liver. And in general, drugs that are considered fat soluble or lipid soluble will move throughout the body easier because we have membranes that will keep some water-based drugs out of them. And so we think about the blood-brain barrier and the placenta barrier in 2 of those. So we're still talking about the pharmacokinetics, and we know that kinetic means movement. So how the drug is moving in our body, or what the body is doing to the drug. So when we talk about distribution, we know that the drugs are going to be, once we get them absorbed, they're going to be moved to areas of the body that have better blood supply. So basically those are the liver, kidney, heart, and brain. And then fat soluble drugs or lipid soluble drugs are going to penetrate usually better, and especially when we think about the brain, because of the blood-brain barrier, it's a lipid material, and so lipid soluble drugs pass over there easier. And when we think about the placental barrier, then lipid soluble drugs cross that easier. Some of the things that can affect the bioavailability of the drug is how rapidly the drug is able to be broken down in the intestinal tract, the dietary habits of the patient, maybe the size of the tablet that they take, and maybe the formulation of the tablet, if it's like an extended release type tablet versus just a regular one. There's different ways that medications move in our body, especially at the cellular level. There's passive diffusion, carrier-mediated, facilitated diffusion, active transport, passive transport. Your book also mentions endocytosis. That's kind of a minor process, and we're not going to really talk about that process. So the first one, passive diffusion, that usually is the movement of molecules down a gradient. And so just for an example, you can think about like sodium. Sodium is going to move from an area of higher concentration to an area of lower concentration unless something affects that. But it's naturally going to follow that gradient. And medications can do that also. Carrier-mediated facilitated diffusion is that to get across the membrane, the drug or the molecule needs another, usually a protein, to carry it across. The difference between that and an active transport is that The facilitated diffusion does not use energy. Active transport does the same thing, except it uses energy to make that happen. Passive transport, passive diffusion, kind of the same thing. So that's the way medications get into cells and across cell membranes. The pharmacodynamics, or how the drug affects the body, is also considered the mechanism of action. And like we said, most of these medications bind to a receptor. And when they do bind to a receptor, usually on a cell surface, they can either be one of two things. They can have a reversible binding, or they can have an irreversible binding. So basically, if they bind reversibly, that medication can come off. So like morphine is a reversible binding, whereas aspirin is an irreversible binding. It stays on there for the life of the platelet. The next terms I want to talk about are medications being either an agonist or an antagonist. And what that means, if a medication is an agonist, then it causes the receptor to do what it normally does. So if you have a beta-1 receptor in your heart, epinephrine binds to that and it causes your heart to beat faster. An antagonist blocks whatever the receptor does. And so you think about like metoprolol, which is a beta blocker. It blocks to a beta-1 cell on the heart, or beta-1 receptor on a heart cell, and that blocks the heart from being able to speed up. So it's considered an antagonist. Then you can break antagonists down into two different classes. You can have a competitive antagonist or a non-competitive antagonist. Basically, the competitive antagonist is reversible, whereas the non-competitive antagonist is not. It binds to that receptor. And so an example of this is a beta blocker. Maybe someone overdosed on a beta blocker, and it's semi-reversible. So the way that you can reverse it is that you introduce something that's a beta agonist, something that's got a whole bunch of beta in it to kind of overcome the stickiness of that the beta blocking medication. And so if you give epinephrine, which is a big beta-1, beta-2 drug, it might be able to overcome the effect of the beta blocker. A couple of other terms that the book uses. One is affinity, and the thing that I like to use as an example for affinity isn't really a medication, it's a poison, and that's carbon monoxide. Carbon monoxide has a like 200% or 200-fold affinity for hemoglobin over oxygen, and so has a very strong attachment or attraction to hemoglobin. So that's an example of affinity. Efficacy is the ability of the drug to cause the desired effect, and your book uses the efficacy for pain between aspirin and morphine, which I thought was a good example. Potency is how medications compare to each other, and the book uses morphine and fentanyl for that, where fentanyl is much more of a potent medication for pain. So one of the interesting concepts is this concept of summation and synergism and potentiation. So when you have summation, when you give two different drugs independently, the effects are measured. So they gave the example of drug A plus drug B equals, reaction C, which is 1 plus 1 equals 2. But some drugs, they kind of work with each other and are synergistic, and so it's no longer 1 plus 1. You give the two drugs, say a benzodiazepine like Valium, and you give a drug like fentanyl, they work together and you get more than the effect of the drugs by themselves. So you get kind of a 1 plus 1 equals over 2, greater than 2. And then the last one is potentiation. So one of the medications that will potentiate a narcotic like fentanyl or morphine is Phenergan or promethazine. And so even though promethazine really has no analgesic type effect, it will potentiate the analgesic effect of the narcotic. The last thing from chapter 1 that I want to talk about is the autonomic nervous system. So the autonomic nervous system is the part that our body does automatically. So you can divide your systems into automatic, or the autonomic, which are the automatic systems, and the somatic nervous system, which is like the skeletal muscle system, the things that we control, have voluntary control over. The autonomic nervous system is involuntary. So when you look at the autonomic nervous system, we can divide it into two systems. We have the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system is considered your fight or flight system. Your parasympathetic nervous system is considered your feed or breed or rest and repose system. Let's talk about the sympathetic nervous system first. We have a whole bunch of receptors in the sympathetic nervous system that we refer to as adrenergic receptors. And these are beta 1, beta 2, alpha 1, alpha 2. And there's actually a beta 3 that most people don't talk about. We're mostly concerned about beta 1, beta 2, alpha 1, and alpha 2. The actual term adrenergic receptor comes from one of the major neurotransmitters in the adrenergic system, which is epinephrine or adrenaline. So adrenaline, adrenergic. There's a good chart on page 16 of your book that kind of summarizes the effects of each of those receptors. But what I would have you remember is that beta 1 receptors, if you think about beta 1 means one heart, beta 2 means two lungs, that generally holds true for most of the medications. So beta 1 receptors really mess with our cardiovascular system. Beta 2 messes with our lungs. And when we look at alpha 1, those work on peripheral blood vessels. And alpha 2 is kind of a negative feedback of alpha 1. So alpha 1 uses a lot of norepinephrine. Alpha 2 kind of turns off the norepinephrine. When you stimulate beta 1, what you usually get is increased heart rate, which is chronotropy, increased contraction force, which is inotropy, or increased conduction velocity in the electrical system of the heart. And so that's dromotropy. Paramedic medications that are adrenergic agonists, adrenergic agonists, also known as sympathomimetic drugs because it mimics the sympathetic nervous system, could be epinephrine, norepinephrine, neosynephrine, dopamine, and dobutamine. All of those in some ways affect either beta or alpha receptors. I like to think of these medications on kind of a continuum where maybe if you draw a chart on the left, you would have your drugs that are pure beta. On the right, you would have drugs that are pure alpha. And so you would start on the left side with the drug dobutamine because it's pretty beta 1 selective and it's almost pure beta. And then the next drug would be epinephrine. The next one would be norepinephrine. And then the last one would be a neosynephrine or phenylephrine. And then dopamine is kind of runs the gamut. It just depends on the dose you're giving, the amount of receptor and which receptors it's actually hitting. So the other half of the autonomic nervous system is the parasympathetic nervous system, and that's also sometimes called the cholinergic nervous system because of the main neurotransmitter, which is acetylcholine. And so this is the feed or breed system, and these receptors, these cholinergic receptors, are broke down into both nicotinic and muscarinic receptors. Now there's not a lot of medications that we give that actually stimulate these receptors. Most of the medications that we give are because of people have gotten into poisons that stimulate these receptors, such as insecticides and pesticides and organophosphate type poisons. So the one drug that we do give that works on the cholinergic system is considered a parasympathelytic. And so when you give a parasympathelytic, it's working against it, or it's a parasympathetic antagonist, and that drug is atropine. It blocks the parasympathetic nervous system. If you think about what the parasympathetic nervous system does, it works on our gut, it works on our exocrine glands, on smooth muscle, it can work on cardiac muscle, striated muscle, central nervous system. And so just think about when someone gets into an organophosphate poisoning, you know, they say they have the sludge. So they have salivation, lacrimation, urination, defecation, gastric upset, and emesis. If they have nicotinic signs, they get hyperglycemic, they get fasciculations and seizures. So all those signs and symptoms are considered resulting from stimulation of the receptors of the parasympathetic nervous system. So that's the end of the review for Chapter 1. Chapter 2 and Chapter 3 both, have a lot of important information in it, and you definitely need to read over those and be familiar with the content and know the content, because you're responsible for that. But there's really not much I want to go over because it's pretty straightforward, and like the different routes of administration and how to do those, we're going to go over in class in some skills stations. The one thing I might mention is that the 6 rights of drug administration, you should know those, and anytime you give a medication, you should be checking it at least 3 times. But you'll find out that this is constantly kind of changing. It's kind of strange. When I went to school, it was the 5 medication rights. Now, it's the 6 medication rights in this book, and now the hospital has 7 medication rights. So I assume one day we'll have a book of medication rights rather than just a few short rules for medication rights. I think it's probably a good time to emphasize and probably repeat that pharmacology is so important to the paramedic level, and knowing this stuff is so important because really some of these drugs that we give have such profound effect on the patient that we have the ability to really, really help someone, to literally save somebody's life. But we also have the opposite side. If we make a mistake, we have the ability to actually hurt a patient really bad or even kill them. So it's a huge responsibility to be giving these medications. So we need to make sure and we learn them inside out, especially the ones that we administer most often as paramedics. Okay, well, Chapter 4 is one that some people have a hard time with, some people don't. It kind of just depends on your understanding of the metric system and math. I know for some people this probably scares you a little bit. Everyone should have kind of a basic understanding of the metric system. You should have gotten that in school, but for some of us that was a while ago. So we're going to go over some of the high points of what you need to know. And then there's 4 formulas that you need to just memorize. And what I have had classes in the year past do is just take a medication card, put the formula on there. So then you end up with 4 med cards that have the formula. And then you can just keep referring to those whenever you're doing math problems until you just know them. The first thing we want to say about the metric system is that there's different units of measurement. And so the ones that we're going to talk about are grams, liters, and meters. So that's volume, weight, and length. So when you look at these, you can also use some abbreviations, and the abbreviations just tell you how far away from the unit of measurement it is. So when you think of grams, okay, you can have 1 gram, or you can have a kilogram, which is 1,000 grams, or then we go the other way where we break it into smaller units of measurement. So a smaller measurement of gram is a milligram, and the next smaller one that we'll use is microgram. And so there's 1,000 micrograms in a milligram, there's 1,000 milligrams in a gram, and there's 1,000 grams in a kilogram. So let's just look at an example of that. Let's say we're giving someone acetaminophen, a tablet, and they come in extra strength, and those are 500 milligram tablets. If we give them 2 tablets, how much have we given them? Well, we know that 500 milligrams times 2 is 1,000 milligrams, and we know that 1,000 milligrams equals 1 gram. Let's take an IV medication. Let's say lidocaine. Lidocaine comes 2 grams in 500 milliliters of diluent. So how many milligrams is that? Well, we know that in each gram there's 1,000 milligrams, and we have 2 grams, so we multiply 1,000 by 2, and so we have 2,000 milligrams in 500 milliliters. Well, if we wanted to find out how many milligrams were in each milliliter, we would just take 2,000 milligrams, divide it by 500 milliliters, and you get 4. So 4 milligrams in each milliliter. And that can be useful when we start using formulas. One thing that I want to mention, is that most of our medications are measured in grams. Some are measured in units. Hardly anything other than fluid is measured in milliliters. But most of the vials or pre-filled syringes or things like that we get usually only have 1 or 2 doses in them. You usually don't have a situation where you're giving somebody a dose of medication and you're having to use multiple vials. If you're having to use multiple vials of a medication to give a dose, you should recheck your math, because it could be that you're giving the wrong dose. For example, if you're giving someone fentanyl and it comes in 100 microgram vials, and when you figure out your math, you have to give 10 vials of fentanyl, well then you need to recheck your math, because a standard dose should fit within the vial. One thing your book talks about on page 66 is how milliliters and cubic centimeters are used interchangeably, and it's right. Cubic centimeters is a measure of volume, and that 1 cubic centimeter equals 1 milliliter. But then it gives you an example of ordering morphine in milliliters, and I don't even know why they put that in the book, because just like it mentions in the paragraph exactly right after that, people don't order medication that way, and you shouldn't take medication orders that way. You should always have a weight-based medication, so they should tell you how many milligrams or how many grams. You shouldn't figure out doses of medications based on milliliters, because medications come in different strengths, and so morphine comes in different strengths. You might have 4 milligrams in 2 milliliters. You might have 10 milligrams in 2 milliliters. Dopamine comes in all different kinds of strengths. So all these medications come in different strengths, so never take it in milliliters. The next thing we're going to talk about is conversions. One of the most important conversions in medication math is converting pounds to kilograms. And all you need to do is take how many pounds your patient weighs. So let's say they weigh 200 pounds, and you have to just divide it by 2.2. So let's say 200 pounds divided by 2.2 equals 90.9 kilograms. Now the reason why this is important is because we administer a lot of medications based on the patient's weight in kilograms. So there is an easier way to figure it out in your head. I obviously just figured it out on a calculator, and that's by taking the number of pounds and dividing it in half. So if you have 200 pounds, you divide that in half, and so that gives you 100 pounds. And then you subtract 10% of that number. So 10% of 100, you just move the decimal place left 1, and so 10% of 100 is 10, and 100 minus 10 is 90, and so 90 kilograms would be your answer. So let's use another example. Let's take a kid. Kid weighs 15 pounds. So 15 pounds divided by 2 is 7.5 pounds. Then you have to subtract 10%. Well, we move that decimal left for 7.5, we get 0.75. So 7.5 minus 0.75 is 6.75 kilograms, and so that's what the patient weighs in kilograms. So some of it you can do in your head, some of it you might have to scribble down, but to me it's much easier than doing 2.2. If we use the 2.2, we get 6.8 kilos versus the 6.75. So pretty close, and if you use either method in the class, it's acceptable. So I'm going to give you a chance to do one, and once I give you the problem, just hit pause because I'm going to give you the answer right after I give you the problem. So let's do 220 pounds. Figure out how many kilos that is. Okay, so hopefully you took 220 pounds. Either this one's pretty easy. Either you divide it by 2.2 and you get 100 kilos, or if you divide it in half, you get 110 kilos minus 11, which is 10% of 110, and you get 99 kilos. So hopefully that's what you got. Make sure and you do the problems that are on page 68 and 69 for converting, so that you feel comfortable with making these conversions. And then there's some on the quiz too. So just make sure you feel comfortable with all those conversions, because you're going to be kind of asked to do them on the fly during skills and scenarios. So let's talk about the formulas. These are found on page 70.